Edna and Yvan, thank you so much for joining me for this really important conversation. Our conversation is going to be focusing on the importance of creating awareness when it comes to mental health and the overall well-being, but also breaking the stigma that is around that, and of course making sure there's access really for everybody who needs it when it comes to care. I want to start with you, Yvan. Here in Rwanda, the conversation around mental health has been really prioritized. Lately, we're seeing a lot of campaigns that are speaking to young people when it comes to alcohol abuse. The First Lady using her op-eds to speak out. The President taking every opportunity that he has when he's giving his state addresses to speak to young people. Why is this a priority, especially right now?
Thank you. It is a priority because I think generally for societies to thrive, they base on their people. And the well-being of the people is central to the development of a country and the continent in that regard. So for Rwanda, is not different. We base the development of our country on our people, and we invest in them. So it's human capital, it's education, it's healthcare, it's agriculture, it's access to services. Particularly for mental health, we've gone through a journey of building our health system so that we respond to all the needs of the population. And we've been seeing a trend recently where alcohol use and abuse has been rising, and the detrimental effects of alcohol is well known, be it to the body, different organs of the body, but also to the mind and the brain. So there's a campaign to do that and to ensure that people can be the best that they can perform to the best ability, so that they can contribute to the development of themselves, but as well as of their countries and ultimately of a continent. So there's a big campaign around that. One is to make people understand the nefast conditions that come with alcohol use and abuse. Two is to provide services, to try and understand why do actually people use and abuse alcohol. Are there social determinants that lead to that? And to try and work with everyone to try and solve those so that people be comfortable and not necessarily need alcohol to be able to function. So it's around that, and it's pioneered, as you say, by the President of the Republic and the First Lady, and it has become a national campaign, and it's going well, and we are seeing fruits that are starting to come out of that.
Okay. And Edna, coming to you, you have been a trailblazer, championing and campaigning against female genital mutilation. This is something that is a harmful practice, and I would like to pick your mind on what regions can learn from the kind of work that you're doing, but honing in on how it actually transforms their lives and societies when there's absence of practices that are harmful like that.
Well, thank you very much. It's great to be in your great country again. And when you ask me questions about female genital mutilation, the word itself describes that mutilation is something which is harmful. And I'm a midwife by profession. I was going to work. I was trained in Europe, where I'd never seen FGM before. It had been done to me, yes. But when I came back to my country, Somaliland, in 1961, and I began to deliver women who had been so badly cut up, so badly damaged, and this damage being superimposed on the complications of pregnancy itself made me rebel against it. I began to ask myself, why has this woman been put through this as a child? Why have we been put through this? And then I learned that this was a practice that predates all the known religions. It predates my religion, Islam. And it's a practice that is condemned by Islam. So if we are practicing Muslims, why are we doing this to our children? And that gave me the courage to go after this harmful practice in my capacity as a health professional and in my capacity as a citizen of this world, as a health practitioner and as a Muslim. So campaigning against it was not easy. It's the part of the world, part of the body that you cannot easily speak about. But then there comes a time when you have to call a spade a spade. You cannot call it anything else. And gradually, people began to understand the harmful effects. We concentrated on the damage it does to the unborn child at the time of birth. So people could relate to this and say, why is this child asphyxiated? Because it was delayed in the part of the body that it was coming through, that was prevented to allow this child to come through as easily as God had created that part of the body. So they could understand it's damaging to the mother, it's damaging to the baby. Islam forbids it, all religions are against it. So we began to learn from scholars, institutions of learning, institutions of Islam, like Al-Azhar in Egypt, the school of theology, a school of Islam. And together we united our forces. And today we have been able to reduce the incidence of female genital mutilation in my country, Somaliland, to about 2/3 of what it was. It's not a victory, but it's a progress towards victory. And it takes a world, it takes all of us together to fight it. And I appreciate governments and also the United Nations, World Health Organization that I served with honor and dignity for many years, UNICEF and others, to have laws and resolutions that condemn the practice. So it's together, it's all of us together against something which is harmful to the health and welfare of our babies and of our women. So thank you for asking me this question. Please go after it. Please spread the word, because it happens in my continent, Africa. It happens in great countries in Africa. And we don't need to have that. We don't need to damage our children. We have to fight bigger battles: hunger, ignorance. We need to fight disease. We need to fight malaria. We need to fight tuberculosis. We need to fight COVID. We have bigger battles to fight. And when our children have survived childbirth, to catch them again at age 6 or 7, catch our little girls and mutilate them only to damage their body, to damage their unborn children at the time of childbirth, is wrong. And we must not do it. We must stop it. And we hope that governments and legislators will join us in this battle. Fathers will join us in this battle to protect their little daughters. Grandparents will join us. Islamic scholars will join us in this battle. And anybody who has that responsibility of leading societies and communities will join this battle. Girls must be protected. Our children need to be protected. Our mothers need to be protected. Our communities need to be protected, for goodness sakes. We have many battles. Let's fight them together.
Girls, mothers, children must be protected.
They must be protected.
Indeed. Eva, I want to come to you. When it comes to protecting the vulnerable, protecting those that need it the most, one of the things that is needed is a task force that is sufficient. Now, the World Health Organization forecasts that there will be a shortfall. Let's talk about East Africa alone of about 6 million healthcare givers. Now, in Rwanda here in 2019, the University of Global Health Equity was launched, and they're doing an incredible job. They're trying to train leaders, they're trying to train healthcare givers. A lot is being done, but can you talk to us about the critical importance of having that sufficient task force there ready to give care for the betterment of the community, but also access to care for all?
Absolutely. Africa faces a critical shortage of healthcare workers generally. The data shows us that in Africa you have 1 skilled healthcare worker per 1,000 people, and the standards generally are about 4 to 5 skilled healthcare worker per 1,000 people. I think only about 3 countries have achieved that on the continent. So we understand the needs of healthcare workers, especially now. The journey we've gone through, maybe in Rwanda, to just give a few examples. In the last 15 years, we were able to reduce maternal mortality by 3/4, infant mortality by 2/3. But right now we're at a crossroads where we need to do tough things, and you need people to do that. As a result of that, we've embarked with different universities, you've named one of those, on a reform called 4x4. It means quadrupling the number of healthcare workers in the next 4 years, especially where we have the critical shortages, like midwives. We need a lot of midwives, like Edna has talked about, to really drive not only maternal care, but also child care. They really play a big role in that regard. But we also need doctors, you need anesthetists, you need nurses, etc. So training is really important, and we're embarking on that. But the second thing is, how do you train a lot of people in a short time? How can you leverage technology to do that? We were just discussing with colleagues here, and we saw good data that shows a physician stationed here in Kigali that can provide training as well as care to remote villages in the northern part of the country. And the data is excellent. The outcomes are about 97% of success rate in providing services, especially sexual and reproductive health services. So we're looking at how we can scale this type of training so that you train a lot of people with the few numbers of skilled professors that you have, using their time to be able to leverage technology to do that. But also, infrastructure is one key component. We are looking at how, and I think this is a move generally that's happening in Africa, how do you use your hospitals to become training sites for the communities and for the physicians and nurses that live around there? With that, you're doing education. 2, you're providing care, so you're tackling issues. And 3, generally you see development of that community as a result of investment that come along that. So the issue that you're raising is extremely important. We'll struggle to achieve a lot of health gains that we see, especially with the rise of competing diseases. So generally Africa had gone through a phase where infectious disease were the main issue, so HIV, TB, malaria, etc. But now we are seeing a rise of non-communicable diseases, which is a little bit more complex: diabetes, hypertension, cancer. And the way to do it is to tackle that is through preventive care. And to do prevention, you need a mass network of healthcare workers. Here in Rwanda and in other countries, we have a large network of community health workers. These are people that are voted by their community, trained in their communities, and provide preventive as well as curative care. So we have about 56,000 here in the country, and they serve as a massive workforce. Right now, we're going a reform to train them and to adapt them to provide some of the critical needs that we see in the community. So those are some of the things that are happening in the country, but I think that we need to work on to scale on the level of a continent.
All right. Now I know our time is fast spent. We'll soon be getting into our parting shots. But before I come to you, Edna, Yvan, Rwanda, when you look at our history, the 1994 genocide against the Tutsi, we have a young population right now. Post-genocide trauma is a real threat, and we talk about healthcare. But again, I keep going back to the fact that mental health is critical to have, all the goals that really Rwanda wants to achieve. Is this something that the ministry is prioritizing? And I ask this because mental health care is expensive. We have great coverage in terms of medical health care generally, but what is being done? Are there intentional steps to address this issue?
We started by trying to understand what is the conditions, what are the numbers here in the country. And what we saw is that 20% of Rwandans have at least once suffered from a mental health event. That's a big number, right? And there's reasons behind that. So we suffered the 1994 genocide against the Tutsi. What we're seeing, in fact, is that there's also transgenerational trauma. There's some research that was done where kids who were born to mothers who experienced that also show signs of anxiety, depression, and other things. So how do you deal with that now? One is to provide services to those people. As a result of that, we have decentralized care to the communities, to the lowest level of the community, primary healthcare level, where we have mental health nurses that can provide counseling services, but also curative services. Two is to break the stigma around that, in the families especially. There's one thing to have access to care. There's the second thing where people actually go and seek care. So now we demystify mental health in the communities, a work that is also chaired by the leadership of the country, where you break taboos, you discuss these are things, you can feel sad, but if you feel sad for a long time, there might be an issue around that. You can talk to a professional and get help. So we are really investing in mental health to the level of the community, as I said, but we're even going further, where the package of community health workers now, these people that I talked about, that deal with households, generally 10 households, can be equipped with tools to kind of detect these mental health issues as early as possible, so that interventions are put in place as early as possible before things get complicated.
Right. Edna, now still on mental health. There's really like a close link when it comes to maternal health. I want to talk about the university, that is the Edna Adan University that you founded. When it comes to creating progressive programs that are able to meet today's needs, what the population needs, this particular issue, thinking this too is quite critical. Is this an area that you're integrating into the programs that you're having now?
Yes, well, of course, before I had the university, I had a hospital in a country, Somaliland, where our health services were totally destroyed. We liberated the country in '91 with just 18 midwives for the entire country and 13 medical doctors for a population of almost 4.5 million people. And what we needed to do is, yes, you build the facility. You train doctors, they take a long time, 7 or 8 years. You train pharmacists and lab technicians, you train nurses. And we focused on human resource development. We need to train people. And when we decided that for our population, we needed at least 1,000 midwives, people thought, Somaliland, a country that's not recognized, is aiming to train 1,000 midwives? They're talking through their hat. But we proved them wrong. We have over 1,200 trained nurses and midwives in Somaliland today. That's a bigger per capita presence of trained health workers than many recognized countries by the United Nations. And I can say that because I was formerly UN. But it takes a team. It takes doctors and nurses and midwives to work together. It takes a vision and dedication to say, what do we need? What can we do with the resources that we have? It's working together. And that training today has lowered maternal mortality. Today we have female surgeons who are doing brain surgery, who are closing spina bifida, who are fixing birth defects, who are doing surgery day and night, who are training other health professionals. And that's where determination comes. And it comes with that vision that brings us all together as a team. As I was saying a little while ago, you have a football team, you cannot run a team with just goalkeepers. You need everybody.
Yes.
You cannot run an air service with just pilots. You need navigators, you need flight engineers, you need cabin crew, you need the team together. And that's what we did. And my hope, Mr. Minister, and my prayer at 86 years old is that Africa will have 1 million midwives. That's how we will fight maternal mortality. And we can do it. We have the resources, and we have proven it, that it works. So while we're training doctors and specialists and neurosurgeons, we need them, yes, but babies are being born today. They're being born every day to women in villages, up on the mountain, all by herself, being delivered by her neighbor, when we could be training health professionals and community health workers who could go up the mountain to the mother on the top of that hill and giving her professional assistance at the most crucial time of her life when she is giving birth to a new life. So 1 million midwives for Africa, that's the way to go. And we will save our mothers who are the pillars of that society, that mothers who, when she dies, will leave us with 4 or 5 orphan kids. Children need their mothers.
Yes, we do.
Husbands need their wives. Siblings need their sister. The community needs mothers. So let us put our energies together, and we can do it. And if Somaliland can do it, anybody can do it.
And we have the people in this room to help make that possible.
Absolutely.
And on that note, as we wrap up, I want to come to you. This is an area that Rwanda has done incredibly well. We have achieved really dramatic gains when it comes to population health, but also poverty reduction. I wonder what the future looks like. What does it look like for Rwanda in the next 10 years?
I think in general, things are progressing well. One figure maybe that can reflect that is in the last 20 years, we've gained a life expectancy of 20 years. So in the 2000, it was around 50 years of life expectancy, but right now we are at 70 years of life expectancy. It comes with its own challenges, particularly in the health sector, is to revisit what will people need in Rwanda in 10 years. Our belief is that you want to assure that people get care the closest to their homes. Really investing in community health workers, reforms. How can a community health worker deal with diabetes, for instance, and hypertension? They've done extremely well in dealing with malaria. Right now in Rwanda, 70% of cases of malaria are treated by community health workers. We want that in the future, 75% of cases of hypertension are treated out of a community without necessarily needing to travel and going to see a cardiologist. It is possible. 2 is to invest in specialized care. As much as you invest in primary health care, you also need to invest in specialized care. Well, how do you deal with people who have different diseases at the same time? So you need care that can combine all that. So we are really investing in our tertiary health care. A lot of university teaching hospitals are coming up. We've started, for instance, in the last 2 months, we did the first kidney transplant in the country. So far, we've done 13. In the last year, we've done 100 open heart surgeries for kids that are born with heart defects. So we're investing in this complex care so that you make sure that people get services as quickly as possible, especially preventive ones. But when there's need to do curative ones, you don't need to send people abroad like we're doing right now, so that you keep people close to their communities.
Edna, as we almost come to the end of our time, could you talk to us about the intersection between politics and diplomacy? You've had an amazing career both in politics and in healthcare.
You have 5 hours?
I think we might have just about 30 seconds for you to help us unpack that and how it can contribute to lasting change.
Well, I think if you don't, you need politicians who also think about the community and not about themselves, not about their political power, not about their individual power, not about their next election, but who think about what they can do for the community they serve and for whom they have been elected heads of states. I'm so honored and proud that we have President Johnson Sirleaf here, who's a living example of what leadership is. It's a balance, balancing politics with social services, with community needs, with education, with security, confidence building in the community. It's a balance that you just need to find. And I'm so blessed to have been born into a country that gave me that challenge all the time. And I think today's Somaliland can be an example, like Rwanda is a shining example of what an African leadership can do. Somaliland is an example of what necessity makes you do, and the art of survival makes you do. Learning to do what you can with what you have is an example that Somaliland can teach the world, because we have survived We are here. We were left for dead 33 years ago. And today we are a country that is known for its stability. I'm the only terrorist, by the way. I terrorize ignorance. I terrorize disease. I terrorize laziness. I terrorize inefficiency. And that's what we need to terrorize.
As we all should.
Yeah.
As we all should.
And it's a balance that you just, God guides you and you do whatever works for you.
Yes.
And you are guided by the love of your people. The people you serve need to have that love and that confidence in you to follow your guidance, to follow your leadership. Girls and students and children to see you're a role model. So you have to learn to serve as honorably as you can, with as much dignity as you can, with as much confidence and determination as you can, and build up their leadership capacities. Let them know that they can do it. They've been told so many times they cannot. It's time we told them that they can do it and show them what has been done.
All right.
Yeah.
And on that note, that extremely inspiring note, we come to the end of our conversation. Yvan, and thank you so much for the incredible work you're doing and for making the time to speak to us today.
Thank you so much. You're great.